So with that, I'd like to formally welcome you to today's webinar, Build Your Behavioral Health Workforce to Support Population Health Management. I'm Kristen King. I'm the Director of Digital Strategy here at Advocates for Human Potential, and I'll be your host today. I'm joined behind the scenes by my colleague, Emily Walker, who's one of our Digital Strategy Associates. And Emily and I are going to be taking care of all of your tech needs throughout the webinar. And we've got quite a webinar planned for you today. So I'd like to begin by introducing today's speakers. And folks, as I say your name, please join me on camera. We'll start with Patrick Gauthier. Patrick is the Director of AHP Healthcare Solutions, and you may recognize him from some of our recent Facebook Lives on our social media. Patrick has 30 years of experience in management positions on both the payer side and the provider side of healthcare. He's developed staffing for behavioral health programs as well as for managed care operations, and since 2005, he's guided many of our clients here at AHP in development of their staffing and workforce development plans. Hey, Patrick. Patrick, I'm going to open up your line, so you are now off mute. Now I'm going to invite Fran to join us. Fran Basche is an AHP Senior Program Manager. Fran has deep experience in providing technical assistance on a variety of behavioral health workforce projects, including the technical assistance for HRSA Bureau of Health Workforce grantees, community-based behavioral health providers in Massachusetts, and she also researched and wrote a provider's guide, How to Use Core Competencies in Behavioral Health for the Substance Abuse and Mental Health Services Administration, or SAMHSA. Hi, Fran.
Hi, everyone. Good to see you.
Thank you. So Patrick and Fran are going to walk ACOs through what we need to know to build a dynamic behavioral health workforce development plan with population health management in mind. So Patrick, Fran, and I are going to go off camera, and we're going to let you take it away when you're ready.
All right, terrific. I'm assuming you can hear me okay?
Yep, you sound great.
All righty. Let's go ahead and dig in. And I want to lay out just a few presuppositions, as we go through the presentation today, because you can see from the title of the presentation that we're assuming or presupposing that ACOs are a fabulous vehicle for population health management. And we're also presupposing that population health management aims or strives to identify and engage the most complex, the most vulnerable populations in whole person care, and that in order for population health management to produce the kinds of results we believe it can, that the ACO in this case would need to build a very dynamic behavioral health solution to account for behavioral health in whole person care. And that in order for that behavioral health solution to really function at its best, your workforce is going to need some special attention. And that's really why we're all here today. I think what we're also going to probably talk a little bit about is that in behavioral health there are some particular challenges. For example, shortage of child psychiatry, for example. So that's what we're talking about today, and our goals for today to demonstrate the link between your population health management and the behavioral health workforce, and then to identify the building blocks of a really solid behavioral health workforce development plan. Now, what we're assuming here, too, is that you've already decided that in being here today, you're interested in building your behavioral health workforce. So do bear in mind that's going to be one of our presuppositions. All right, so what is population health management? And I'm just going to provide a working definition for us here. Population health management refers to the process of improving clinical health outcomes for a defined group of individuals through improved care coordination, and patient engagement supported by appropriate financial and care models. And we've provided you with a graphic here to help you understand just how far-reaching population health truly is. And you can see the source for that there as well if you're interested in taking a look. But that definition, for example, comes from the American Hospital Association, where I think there's a real recognition that with the right care model, the right financial model in place, we can really address some of the, of course, morbidity, mortality, and the economic burden of care that doesn't quite meet our standards in this country anymore. And I want to make sure that you take full advantage of the graphic we've provided here for you. I think it does a great job of illustrating that. All right, and Kristen, it looks like we're at our first poll, so I want to invite you back to walk us through this.
Okay, excellent. Thanks, Patrick. All right, folks, so we would like to hear from you about your current level of behavioral health integration in your population health management program. So you'll see immediately below the slides, we've had a poll appear, and we're asking what is that level. So go ahead and click the answer beside, click the circle beside the answer that best describes your situation. Are you making referrals in the community, but you're not yet integrating in your practice? Have you started integrating, but it's not quite fully implemented? Is it fully implemented, but it's just not going quite how you want it to do, so you have some work to do? Or is it fully implemented and it's going great? So pick the answer that best represents your organization's current status, and if none of them does, that's okay, but go ahead and type in the chat box and tell us what would be a better way to describe what's happening in your program. And I see the votes are still coming in, so I'm going to give folks about like 5-10 more seconds to select their answer. Remember, there's no submit button, so it will submit as soon as you make your selection. And I'm going to go ahead and close that poll in 3, 2, 1. Excellent. Okay, Patrick, I'm going to broadcast these results so everyone can see what we're seeing. And as we can tell, there's a clear winner here. 6 of our participants are saying that we've begun integrating behavioral health in some areas, but it's not fully implemented. Is that what you would typically expect to see, Patrick?
It sure is. You know, we've been talking about integration for a long time, both in the behavioral health sector and in the general medical and primary care sectors. So this is not a new topic, and I think certainly the Affordable Care Act and its emphasis on ACOs and population health management has really prompted a lot of work in this area. But what I'm happy to see is that there's, while a lot of work has been done, there's still a lot of work to do. And I think it's encouraging that, upon an honest appraisal of where we are, we've got folks saying we're not quite done, we've got more work to do to fully implement it. And I think that kind of honesty is important right now.
All right, thanks, Patrick. I'm going to go ahead and hide that poll, folks. We'll have another one later. But Patrick, why don't you take us into the next portion of the presentation?
All righty. The next portion of the presentation, I'm actually going to invite Fran, I believe. Is it time to invite Fran to come and join us, or is this again my...
Yep, I think it is.
All right.
Take it away, Fran.
So we wanted to just offer you a definition of what workforce development is. Workforce development aims to improve behavioral health outcomes by ensuring that future and current behavioral health staff have the competencies, credentials, and performance necessary to achieve these improved outcomes. This is accomplished through recruitment, onboarding, retention, supervision, and training efforts. A workforce development plan answers the question, what do we need to do to develop our workforce? And this is a workforce development framework that we've developed and we've used very successfully across the U.S. You can't achieve any organizational success without the people to implement your strategic plan. This process should not only identify workforce needs, but also key strategies, goals, processes, and behaviors needed to affect possible change. And you'll see on this framework, when we talk about the people, it's telling you where some of these people are going to come from: colleges and universities, training institutes who are graduating people. Oops. I don't know what happened there. Sorry.
Fran, I can jump that for you. Give me one
minute. Okay.
There you go.
I may stop touching the pointer. It's going to tell us where some of those people are going to come from, what they need, the competencies, the knowledge, skills, and abilities. And when people use the word competencies, that's what they mean. As well as what they're going to do. They're going to be implementing evidence-based practices, again, to achieve the triple aim that Patrick mentioned. And so what is a workforce development plan? A workforce development plan is a living document, first of all, designed to assess and forecast the needs of an organization to ensure that it has the right number of people with the right skills and experiences and competencies in the right jobs at the right time. Workforce development planning is a key element of any of these strategic plans, and it really has to be dynamic. It has to take into account local, national, and state trends and a variety of other factors. Obviously, none of us could have predicted this pandemic, but there are other things that we can take into account to think about what is needed in the workforce. So sometimes it's helpful to know what something isn't when you're thinking about what you want to achieve. So what's the difference between a staffing plan, a training plan, and a workforce development plan? Staffing plans are often very tactical, focused on operations and on meeting headcounts. For example, how many licensed mental health professionals do we need for this year? Often with a one-year focus. Training plans also have an operational focus over a one-year period. For example, we have 35 behavioral health professionals, and we want to make sure that they're all trained in, I don't know, trauma-informed care or motivational interviewing this year, whatever you have deemed to be important. In other words, a workforce development plan is strategic, addresses multiple areas, spans a 3 to 5 year period, and is constantly evolving, not static. I am sure all of you are changing your workforce development plans lately because we have had so much change. For example, you might ask, how can we increase the number of licensed clinicians to fill the need we have anticipated? You might be asking, if our current clinical staff were to work at the top of their license, could we use the growing cadre of recovery support workers and other paraprofessionals to help fill those gaps? Or we anticipate X number of retirements by baby boomers, so we're going to need to fill those spots. Are there any staff interested in working part-time after they retire? And finally, how do we attract a diverse group of professionals that more closely matches our community? So those are just some of the questions that we would suggest you ask and can be answered by a workforce development plan. And now I'm going to turn it back over to Patrick to talk about workforce development and innovation.
Terrific, and I'm assuming everybody can hear me. Thank you, Fran. Workforce development plans give us a really terrific opportunity to think differently about what it is that we're doing and how we do it. And for example, with respect to recruiting, Fran, you mentioned recruiting. This might be the opportunity to take your recruiting strategy onto digital platforms that perhaps you hadn't thought about before. It might be an opportunity for you to be thinking about internships. There are even providers today who are thinking about apprenticeship type programs, and certainly you can work with your state to figure out how are they approaching the workforce even within your state to see if you can be part of an initiative the state is undertaking. A good workforce development plan is also going to challenge everybody to think about how they collect data to make decisions about your workforce development priorities. And that data, whether it's in your EMR or EHR system or in your outcomes or your quality data, if there's an absence of that data, I think this is an opportunity for you to think about how we're going to collect that data and to inform and work with your IT department, your analytic folks, to help them understand what it is your needs are. And I'll give you an example of a need with respect to data, understanding what are our costs associated with recruitment and hiring new staff. And is there anything that we can do to drive those recruitment costs down? What can we do differently again? What can we innovate to keep our costs in check as it relates to recruitment? All right, let's get into the components of a solid workforce development plan and get to know this a little bit better. Certainly this is a plan that is much more robust than a to-do list or simply a checklist of things to do. This is a tool and a resource that is going to allow you to look comprehensively across what it is you're doing today, what it is that you have in place today, what it is that you will need in the future, and how it is that you can plan to close those gaps. So let's take a look at the assessment. This is an opportunity for you to look at what it is that affects your workforce externally and internally. I think there's some examples here that I'm going to go ahead and share with you. There is increasing diversity across the country. There is an increasing reliance upon telehealth, for example, in this country as it relates to COVID-19. There's a real shift toward the integration of behavioral and primary health care. Payment reforms, some of the employment issues that might be present in your region of the country. How do all of those external factors then impact your workforce? Internally, the behavioral health workforce is one that we know is an aging workforce. How does that look in your organization? Internally, you may also be thinking about mergers with other organizations. Is this an opportunity for you to look at behavioral health partners from that standpoint of merger, acquisition, some form of strategic partnership or joint venture even? How does that impact your staffing? What kind of behavioral health program are you looking to deploy? Is it an inpatient, an outpatient program? And certainly there are implications for workforce depending on whether or not it's inpatient or outpatient. Mental health, strictly, substance use disorders, or a combination of both? And to what extent are you leveraging technology in your behavioral health program? All right, let's take a look at your workforce profile. Okay, so what are the characteristics of your current workforce? What are their competencies? You heard Fran talk about skills, knowledge, abilities. What level of licensure and credential do you require people to have? Are you deploying those folks within your organization using real tight scope of practice management to make sure that people are always operating at the top of their level of licensure or credential? What roles and functions do you have people playing? For example, a clinical director, a medical director, clinical social workers. And how do those align with the types of folks that you're serving? Are you properly structured to meet the demographic, socioeconomic, clinical, social needs of the people that you're serving? Then what types of supervision are currently being provided, clinically and administratively? And really importantly, we believe at AHP that a career ladder for each position is absolutely essential. There have to be opportunities for growth and advancement if people are going to feel engaged and valued and as though there's a future for them within your organization. So you need to be thinking through what type of career ladder do we have available, and do we make it known or available at the point of recruitment when we're working to engage people and retain our people? Do we have that career ladder in place, and how do we make it visible? Let me give you an example of how you can make it visible. This is one that we put together. You can see the different functions along the bottom: skills, knowledge, abilities accumulate, and you can see with time that a ladder begins to emerge. The various rungs on the ladder keep growing and adding so that people can feel the opportunity, see the opportunity in front of them to continue to grow with the organization. That's the kind of career ladder that we're talking about making available for folks. All right. Now then, let's talk about your future needs, and what areas do we believe we're going to need new, additional skills moving forward. Right now I've given the example of social needs, and I don't need to tell you, social determinants of health, social needs are front and center on everybody's mind today, and everyone, I think, is working very hard and diligently to address social needs. Well, how does that impact your workforce? And what areas might you need more individual providers? Perhaps you're looking to deploy licensed clinical social workers into primary care practices. You might have 25 primary care practices that you're looking to integrate behavioral and primary care. So that would have, of course, a real material impact on the kind of recruiting that you need to do. It might be that you need more prescribers and, working with nurse practitioners in this regard might be what your future holds. Are there regional considerations that you need to take a look at? Are there mergers and acquisitions, as I said earlier, that are taking place or that might take place if you were the one to pursue them that make a tremendous amount of sense? And then what is it that we can learn from some of these events that are taking place, some of these phenomena that are taking place around us, like the opioid epidemic, like the COVID-19 pandemic, and how do they impact us? And I'll give you an example where we're working with one ACO and deploying people who can teach people with serious mental illness, chronic addiction, a variety of disabilities, people who might be a little older, who might not be as accustomed to technology, to embrace the technology and use it at home. So people are being deployed directly into the home to help their patient population adapt to telehealth technology, patient portals, and who would have known, a year ago that we would need to deploy technology, help desk type people into home health kinds of situations. But that's what the future has given us to work with, and that is what we're in fact working with. Then you've got to be prepared to close the gap based on your assessment of what you have today, based on that profile of your workforce, and based on what the future might hold, and there might be a little speculation in there that you need to do. You need to be able to answer the question, how do we get from where we are today to where we need to be with our workforce? And that really becomes the stuff of the essence of your workforce development plan. And Kristen, it looks like that brings us to another poll, so I'm going to invite you back, please.
All right, yes, let's look at our next poll. So we want to know if you have a workforce development plan for your behavioral health. So go ahead and let us know what your current status is. Do you have no plan at all? Have you started one? Is it fully developed but not quite working right? Or it is, oh wait, hang on, you can't vote. There you go, now you can vote. Or it is fully developed and it's working really well, but you're constantly refining it. So go ahead and select the option that best describes your organization. And again, there's no submit button here, so as soon as you click the circle next to your chosen answer, it will automatically push that answer to us. And after the votes slow down, I will show these to everyone. We've got a tie for first right now, so I want to make sure everyone has the chance to vote so we can see if this is a true tie or if we just have some folks who are still selecting. Oh, we're tied for first and second. Okay, interesting. All right, so I'm going to give you about 5 more seconds to get those votes in. So select your answer in 5, 4, 3, 2, 1. Oh, and someone got in just under the wire. We had to shift it. Let me broadcast the results so everyone can see it. So here's what I'm seeing. We're kind of evenly divided between no plan and having attempted to start one. And then we were also evenly divided, but with smaller numbers, between fully developed and not successful or fully developed and in improvement. But at the last second, someone switched from not successful to can always be better. So Patrick, tell us what this means.
Well, I think what it means is that the most important data on the screen are those first two, that no, we don't, or we've attempted. And listen, like we saw with the first poll, while this isn't new, the idea that we're going to integrate behavioral health and medical teams, I think we're in the early stages. Clearly, we saw that before. We've seen that all over the country here at AHP, and the folks that we work with are in more nascent early stages of development. And it's not a surprise to me that workforce development planning, people are beginning to work with it. They're attempting, they're making some attempts. I think oftentimes, and I really liked Fran's discussion of what's the difference between staffing plans, training plans, and workforce development plans, is clearly people that I've worked with approach workforce development from the staffing plan standpoint. And they're thinking just purely in terms of, I think we need, 2 nurse practitioners and 3 licensed clinical social workers and 1 PhD psychologist, without having taken the time to really look at it strategically the way that a workforce development plan does. So I'm not surprised by the answers. I think they make perfect sense. And clearly there are some people who, you can see it in that last answer, who do have a more robust approach, and they've had some success with it because they've been early adopters. And there are some people around the country, make no mistake, who are early adopters and have done a bang-up job with their integration of behavioral health in a ACO and population health milieu.
Great. Thanks, Patrick. And this is a great segue for us to bring Fran back. Fran's going to walk us through what some of those domains of a plan could be. So Fran, when you are ready, you can move on to the next slide there.
Thanks, Kristen. So we wanted to help you understand some of the components of an effective workforce development plan. There are 6 domains that we think will help you to get to where you need to be. The first is care coordination and case management. You can't do integrated patient-centered care without multidisciplinary teams, and those individuals and the teams need a variety of competencies to effectively coordinate and manage care. The second domain is clinical programs, evidence-based practices. In order to do effective population health measured in terms of outcomes and quality, you're going to need to implement evidence-based practices. Here's the catch. In order to implement with fidelity, you really need a strong workforce development plan to pull that off. The third domain is, find my button. The third, can everyone see that? The third domain is integration of primary care and behavioral health care. This domain focuses on all of the strategies and tactics that you need to make sure integrated care happens. Obviously, it happens with the workforce. So let's take a simple idea of a warm handoff. It requires not only the right workflows, but the right people in the right places with the right skills to make that handoff. Otherwise, it's not going to work, and you're not going to get the outcomes that you want from that process. I'm having a little trouble with my buttons. The fourth domain is technology adoption and data analytics. This can be everything from electronic health records, clinical decision support systems, and telehealth. A robust population health management initiative or strategy requires analytics staff who understand behavioral health clinical measures to support point-of-care decision-making and process improvement. The fifth domain is the shift to value-based reimbursement. As Patrick mentioned, value-based reimbursement is here to stay. It started, has shifted over the past 5 to 10 years from payment based on the volume of care provided to the value of care provided. And because value is a function of understanding the interplay between utilization, outcomes, quality, and cost, it requires staff who are much more savvy about large behavioral health data sets and how to understand them. Finally, the last, it's already up there, sorry. Finally, the last domain is continuous quality improvement. As we mentioned earlier, staff at all levels, from clinicians to your backroom data analysts, need to understand those large behavioral health data sets, in addition to traditional claims data, in order to truly realize effective behavioral health management. So to see how these domains can be applied, we want to walk you through the workforce development planning tool that you'll be able to download at the end of the webinar. And what we're going to do is walk through the tool, but with part of it filled in the first domain of care coordination and case management as an example. So Kristen's going to bring up a PDF of the work plan, and am going to walk you through it. So I'm just going to, okay, great.
Okay, Fran, so that's
Thanks.
the whole tool, and go ahead and zoom in as far as you like, but I wanted folks to see what the big picture of the tool is before we start.
Yeah, so we have the, we have across the top, we have the domains that we just went over, as well as the time period. And over to the left, we have a number of the questions that you are going to want to answer to develop a workforce development plan. So this is a plan that we did for an ACO that we work with who focus their workforce development plan on paraprofessional care coordinators. These non-clinical, non-licensed staff work with patients to address a variety of social determinants of health that might prevent access to both physical and behavioral health care. This ACO also had licensed social workers who were doing case management. But sometimes it was a little difficult for them to tell where a care coordinator's job ended and the case manager's job began. And this speaks to the issue of roles and functions that Patrick mentioned earlier. What happened was that the more highly paid social workers were not working at the top of their license, and the care coordinators also were not as effective as the ACO wanted them to be. And there was also no career ladder for the care coordinators, which could improve staff retention. I'm just going to bring this down here. Okay. So the ACO had 3 goals in asking us to develop and implement a workforce development plan. They wanted to ensure patients' behavioral health needs were being met through improved care coordination and case management. They wanted to reduce barriers to care by addressing those social determinants of health. And they wanted to improve clinician satisfaction by reducing the burden of non-clinical tasks. And by the way, this obviously also would save the ACO money if the more highly paid folks were only focused on clinical issues. In order to understand the competencies needed for care coordinators, we conducted an environmental scan to determine the best practices for care coordination and the commonly understood competencies for that job, conducted key informant interviews, reviewed job descriptions for the care coordinators and the case managers, and we used this to develop a new list of competencies that could be used to hire, supervise, and evaluate care coordinators. And I'm just going to scroll down to the next page. So we also use this information to develop a scope of practice that would differentiate between what care coordinators do and what clinicians do, to avoid the confusion between the 2 roles so that clinicians would be working at the top of their license. Once we had the competencies and the scope of practice, we conducted a gap analysis and we made 2 recommendations to the ACO. We suggested that they improve the care coordinator's performance through training, through competency-based performance management, and development of practice-based outcomes. So not just the individual outcomes, but the practice-based outcomes. And we also suggested that when it came time to recruit staff for care coordinators, that they recruit different types of staff, people with different backgrounds, and we'll explain about that in just a second. We also thought it was very important to address the issue of diversity, which of course is a very important part of patient-centered care. And so we included a provision of culturally relevant care coordination as a competency. We reviewed the job descriptions and recommended incorporating the new competencies and a new understanding of these jobs into job descriptions, once again, to make sure that they were hiring the right people, they were using that to supervise and to improve work. We asked the question, can existing staff do this job? And the ACO felt fine about keeping the existing staff, but when openings became available, they would recruit people with different backgrounds. They didn't need to hire any more staff. Of course, the how many is always a good question. And the time period for employment, these were permanent employees. They were not temporary or contract employees. We did not just work on salary issues with this ACO per se, but obviously that's a critical piece of any analysis that you are going to do. We did talk with them about the recruitment process, and we discovered that all of the care coordinators were former certified medical assistants. In the state where this ACO is, those are the folks in primary care settings who are the ones to take a patient's temp, BP, weight, and they were mostly interested in physical health issues, and some did not have either an associate's or a bachelor's degree. We recommended that when there were openings, that the ACO hire people with more experience in human service fields, so Department of Children and Families or community-based nonprofits, folks who had at least an associate's degree to ensure that they would have the right knowledge, skills, and abilities to be a care coordinator. And we suggested that they use the competencies when they do hire new people, that to help guide what kind of onboarding, training, and various processes they may go through. We all know when we have a new employee, we need to figure out, okay, what does this person need to know in week 1, week 2, week 3, and the competencies could help guide them with that. We also worked on engagement and retention strategies with this ACO. We all know that turnover is a big problem across healthcare, and so is engagement. This morning, I happened to see a study that was conducted pre-pandemic that said that 56% of healthcare workers are disengaged. That can lead to a variety of problems. And really, I read another quote, all coincidence this morning, that in order for your organization to have an engaged workforce and succeed, you have to have the right person in every chair. And really, that is the goal of a workforce development plan. We recommended, in terms of a career ladder, which would help toward retention, that they develop a career ladder that would have a 2-tiered job description for care coordinators. So, care coordinator 1, care coordinator 2, with increasing levels of competencies and compensation. Let me just scroll down a bit. And we also looked at supervision. Supervision is a question that is often ignored and is absolutely critical to an effective and engaged workforce. We discovered that the care coordinators were supervised by the office manager, the same person who, made sure that the copier was filled and there was coffee in the waiting room. These folks had no background in care coordination, social determinants of health, or behavioral health. We recommended that the ACO either hire a behavioral health clinician to do the supervision or create a new position of care coordinator team lead, and where that person could supervise the care coordinators, either all of them or 2 or 3 team leads could supervise the less experienced folks. And this also could lead to an additional step in the career ladder by allowing care coordinators upward mobility. We also suggested that they use the competencies to measure individual staff performance and use the competencies to develop a competency-based evaluation tool. At the same time, we suggested that this was a good opportunity for them to develop and use measures that capture possible practice outcomes that go beyond an individual coordinator, to focus on how care coordination is impacting patients' experience of care. For example, if the ACO looked at patient engagement, they would be able to see how consistent is it, what's the length of engagement, to what degree are social needs resolved. They could also review these measures with the care coordinators and the entire team assigned to that practice to have a better understanding of where process improvement could occur and to increase competencies. And the last thing, I don't know if people can still hear me.
Yep, you're still good, Fran.
Okay. I've lost network, but that's okay because I'm on the last one. The last thing we did was to suggest that they use the competency assessment to guide the training. How do you know what to sign people up for? How do you know whether to approve them going to a particular conference or training or to bring folks in to train your staff? If you have that competency guide, and again, that career ladder that Patrick showed you to move people up the ladder, that is going to help you with competency-based training. So I am now going to turn it back over to Kristen so you can take us back to the slides.
Okay, excellent. Thanks, Fran. So I'm having, I also had the same hiccup that you did, so I might need Emily to change our layout for us. Emily, is that possible? Thank you. And then Emily, if you could also unmute Patrick, because I am unable to do that as well. Thanks so much.
Patrick is off mute.
Okay. All righty. Well, I think we've got a sense of what the next steps are. For anybody who's interested, they're up on the screen. Complete the plan for all 6 domains once you've downloaded the tool. Be sure to develop a budget around what it is that you're doing and cultivate buy-in, and then develop a strategy to implement that plan. I think, the other thing I'd like to say about everything that we've been talking about today, if I can advance the slide, there we go, is that there's just no question in my mind ACOs are an ideal model within which to address population health. And I'm glad that we've made so much progress around the country with the ACO model itself. It's the most encouraging thing I've seen in my 30 years. The other is that population health really must account for behavioral health. And the data doesn't lie, folks. What we know about people with comorbid, complex, chronic conditions involving serious mental illness, involving chronic substance use disorders, has to be accounted for in a really robust behavioral health program. And that when we do that, then we're addressing the needs of the whole person. But in order to pull this off in an ACO construct or context or any other integrated delivery system, we really need a very well-designed, well-thought-through workforce development plan to get us there. These things are inextricably linked in my mind. So that's the punchline. Kristen, I know we've got some questions, so I want to get back to you as quickly as we can.
Excellent. Thank you very much, Patrick. So, folks, for anyone who hasn't yet, hang on one second, let me move to the slide where you can actually download the tool. Okay, so we've got the tool available for download in the lower left-hand corner of your screen for those of you who are watching live. For those who are watching in the replay on YouTube, you will find the link to the place where you download that tool in the YouTube video description. So we're going to let you grab that. We'll leave that up available for download for the rest of the conversation today. And now we're going to shift gears. We're going to shift into answering questions. And we've got a hefty list of questions. I know Fran's internet has gone down, but Fran is still with us on the phone. So Fran, let me just get like a quick sound check from you and make sure we're hearing you okay.
Yep, I'm here. I think I'm here.
Yes, you are.
I feel like I'm here.
Okay, beautiful. All right. So I will let you all kind of determine who's the right person to answer each question. But here's the first one that we've got. The person writes, we can't find enough psychiatrists to treat all of the adults, let alone the kids, in our service area. What should we be thinking of doing in terms of a workforce development plan to address this issue?
I'm happy to take a first swing at that.
Okay.
Kristen, it's an excellent question. It's one that comes up often, and you know, we have a real shortage of psychiatrists in this country. There's just no question about it. So I suppose the first part of the answer would be to advocate, to work with your academic medical centers to encourage, you know, the cultivation and then harvesting of as many psychiatrists as we can in medical schools around the country. I think we need to do more to promote the field and see if that doesn't help, but that's a very long-term solution. In the short term, this is where, from a strategic standpoint, you can sit back and say, does this require a psychiatrist full-time, or is this something that we can contract for part-time? Or, alternatively, is this something that we could do with nurse practitioners who have the additional training and expertise in psychiatry to work with us in the same way that an MD psychiatrist might? So sit back and ask those kinds of strategic questions. Depending upon the demand you're experiencing in your setting, you might find that there are a variety of answers that you can explore. The other thing to explore is, and again, depending upon how great the demand is and what your resources are as you assess those resources, is this something that we want to build our own capacity for, or does it make more sense for us to partner with somebody, perhaps somebody who could co-locate with us and we could enter into a strategic partnership? So I love the question because unfortunately there's no easy answer, but it does force you, it's the kind of question that forces you to think outside the box about the variety of options that you do have.
Thanks, Patrick. And you know, we had a couple of conversations on our Facebook Live series that speak to that as well, talking about the value of those partnerships and how to think about integration. So I want to refer folks to check that out if you haven't seen those conversations, and we'll give you a link to our YouTube channel and our Facebook where you can find that if you missed it the first time around. All right, here's another question. This might be a Fran question. I'm not sure. You all will have to tell me. But the person wants to know, well, they say, we'd like to add peer recovery support specialists to our organization, but we're not sure where they fit in strategically or organizationally. So the question is, how do we figure that out?
I can start that, but I'm happy to have Patrick jump in with it. I think one of the first things to do is look at those roles and functions like we did with the ACO that I described. What are people doing now that could be done by someone in a recovery support role, as well as what's missing? Recovery support peer specialist, they have many different names, bring that recovery-oriented focus. They are usually people who are in recovery themselves and can really support people who have behavioral health disorders and are moving into recovery in a different way than folks who may have a particular licensed credential, master's level staff person. So looking to see what are the needs, where could you draw people from? Are there recovery centers around your community or programs that are graduating folks and training them? To really identify what the role would be, what would they bring to it, how would you integrate them in with your staff to make sure that your staff feels comfortable with them and that the peer support specialists or recovery support specialists feel comfortable working with the staff, to make sure that everyone feels valued and understands what their job role is. So a workforce development plan that looks at the gaps, develops a scope of practice and competencies for each of those roles will help you be able to figure out whether and how to bring in recovery support specialists. Patrick, I don't know if you have anything to add to that.
No, other than you began to emphasize the integration, how you integrate them in your practice and in your milieu. And, we've talked about this before, too, in our Facebook Live presentations, that culture is a big deal, and the peer support recovery specialists, bring a culture of their own, a culture of recovery in the recovery 12-step movement in particular, and that you're going to need to account for that. That's a thing. It's a real thing, and they'll need to better understand your culture. You'll need to understand theirs. Give it time. Pay attention to it. Don't act or hope to act as though that cultural dimension doesn't exist, because it does.
Great. Thank you both. I just looked at the clock. It's time to wrap up. But for those of you who submitted questions, if we didn't get to it live today, we will circle back around with you and make sure you get the information that you need. So again, thank you for joining us. If you haven't grabbed that tool yet, go ahead and download it, live users, in the lower left corner of your screen on Adobe Connect. For those watching on the replay, again, you'll find that link to access the tool in the YouTube video description. And we also want to invite you to connect with us on social media. You can find us on Facebook, on Twitter, on LinkedIn, and on YouTube. And please join us next month for Whiteboard Wednesday on Facebook Live. We mentioned this event a couple times as we were talking about the Q&A. On November 18th, we're going to come back together with Patrick and our lead consultant on Medicaid Managed Care, Chris Cunahan. We're going to talk about innovation and future planning for ACOs. You don't want to miss that. You can also find all of our past Facebook Lives on Facebook, of course, as well as on our YouTube channel. If you need assistance or want some outside perspective as you use that workforce development plan template, Patrick and Fran would love to hear from you. Their contact information is here on the screen. We will also drop that in the chat box for you. On behalf of Patrick, Fran, my digital strategy team, and the rest of us here at AHP, thank you for joining us. We look forward to seeing you next time. This concludes today's broadcast, and you may now disconnect. Have a great afternoon, everyone.